to prevent falls in hospitalized patients at Base Hospital, Udugama. The authors are Fernando GHS, Pacharana PPAS, Seniviratna AAS, and the paper will be presented by Fernando GHS.
Good morning again. I am Dr. Susantha, Medical Superintendent at Base Hospital, Udugama. Base Hospital, Udugama is a 150 bed hospital type A. We have all main specialty with 5 bed ICU and 24 hours service in theatre complex. I think I don't need to justify need of intervention to reduce hospital fall, because previous presentation from the Karapit here clearly justify why we need intervention to prevent hospital falls. The patient falls are most common adverse event reported in the hospital, especially developed countries, maybe because most of the people are elderly patients. 2% of hospital patients fall and 1/4 result in injury. These are the findings from the developed countries, and 10% result in serious injury. The injuries and fallen, I don't need to justify, already mentioned. In our hospital, 10 patients have been fallen within 18 months. Because we do this intervention not just only to address our issue as a proactive intervention. So we know falls are happening everywhere. Even my previous hospital, even Karapiti, I was director in 2017. I heard it's the only incident reported to the director without informing to them, because they think this is something happened legally, the in-charge nursing officer will be affected. Therefore, without implementing, automatically they report this incident. I think all directors know that. We identify root causes from our quality management unit. We have quality review meeting. There we identified that because of high workload, we have only 70 nursing officers where we had 250 nursing officers in my hospital. My whole hospital with theatre ICU run with 72 nursing officers. Their workload is very high. We don't have assess the risk, and the poor documentation, poor education on staff values as patients, and lack of staff awareness. These are the reason why these 18 patients were fallen. 10 patients were fallen in the bed or the washrooms. Then our objective was to reduce patient fall during hospital stay. I think this intervention, as a small hospital, we easy to implement, and we can benchmark to the other hospital as well. The intervention project was developed with the help of all the stakeholders, including consultant medical officers and our nursing staff. Then with them we developed the risk assessment format, risk assessment chart, and we developed this dashboard where I will explain that, and prepare this fall and risk tags and sensitization of all the staff on the intervention, and conducting risk assessment on admission and implementation of the preventive project. This is a stakeholder meeting we conducted with our staff members. This is a risk assessment chart. This was developed with the help of our consultant and doctors and nursing officers. The risk rank was developed by with the knowledge and experience of consultant and doctors and nursing officers. We collectively give information to them and ask them to put what is the risk of fall rate for up to 1 to 5 for these reasons. All give some mark, we collect at all and get the average number. This is a risk of fall number. We develop this one. There are standards in national, international, but we develop as a practically. It will be easy us to implement if we get information from our staff. According to that, if it is a risk, if we identify as a risk, these are the things we are doing for the patient. You can keep in high risk patient in a bed protected with bar, offering bed near to the washroom to the patient who have difficulties, keeping risk tags at the beds, making the entire staff well aware, educating staff to offer friendly service to the risk patient, allowing to keep a bystander for high risk patient, notifying fall risk places in wards, preparing disabled toilet to each ward, educating the patient on risk of fall and preventive actions, fixing bed alarm beds, still we are not did, keeping the floor dry as much as possible. These are things we should, if you have identified as a risk of fall, we have to do these things according to that. This is the risk categorization. If the once patient come to the ward, nursing officer and the doctor collectively fill this format as a collective effort. After they fill the chart. If the risk is more than 4, we take as a high risk. All the preventive action we take, and addition to that, we recommend to keep bystander. If it is 3, it's a moderate risk. All the preventive action without bystander, we don't recommend to keep bystander. For if it is moderate, it's low risk. Awareness of both patient and staff are done this. On admission, all nursing officer, doctor fill the risk assessment chart, identify the risk of fallen. If we identify the risk, all the measures I explained before will taken. Then this is our risk board. If there are not 3 patients in the risk of fall, we notify here there are 3 patients in this ward who are risk. Then all the entire staff, even minor staff, know about this thing. They know if this is there are a number of patients, they know they have to do something these patients. It is not only this, we are doing this quality improvement project. There are several dengue hemorrhagic fever, allergy patient, fasting. If there are such a patient, we mark this number here. All are know these patients available in a ward. Once this happens, we give all the precautions has been taken, and this is a risk for tags. There are tags. If it is for risk of fall, this tag is attached to that bed. Then all know the visualization is very efficient or effective. Therefore, we can visually see there are no patient. The risk tag also there. All are know this patient risk. Then even patient know we have educated. Then they know I will be fallen. He will get precaution. The bystanders know. Even minor staff all are know she will be fallen. Therefore, we take necessary actions to prevent falls. These are intervention was commenced on 1st of July 2023. Observed for 3 months. All the staff members are very satisfied on the project and adhering to the intervention. Number of patients identified during risk assessment 20 identifies a risk of fallen, and intervention was done and no fallen reported during 3 months. Patient falls are reported during hospital stay was harm. Falls can be reduced by implementation of prioritization of risk patients. Visualization is more practical, even a busy environment to reduce risk. Sorry for mistake. This is a project. This is why I implement in my hospital. This will be can be implemented to the other hospital and even Karapi. Thank you.
Thank you, Dr. Fernando. It was a very interesting and a very comprehensive study that you had done. And Yeah, I think it's really important because we have done this intervention study and we have developed this particular instrument also, which is also very important, which can be used by other hospitals as well. So it's open for discussion now.
Thank you for the presentation and taking this initiative to reduce the risk of falls in the hospital. You have mentioned that there were 10 falls over the 18 months, and can you mention the incidence of falls like?
You know, the incident reporting system has been implemented in our quality secretarial since around 5 to 6 years. In our hospital, incidents reporting system has been establishing from 2029. Each and every incident reported to our incident reporting system, we are doing evaluate. We do each and every incident at our quality review meeting.
No, what I
But-
wanted to
yes.
know is what is the total number of admissions during that period, of which you have got 10 falls?
Yes. Actually, now I can't tell, but daily our admission is around 70.
Okay.
Average admission 70.
One more. You have mentioned that you have categorized the risk based
Yes,
on your
yes.
score. And may I know how you determine these cutoff values?
This is why focus group discussion. This is one of method. We are developing some tool with professionals.
Mhm.
We do all the consultants, doctors and in charge nursing officers. We sensitize all the participants regarding this our value, and they ask them to study, learn about this thing, get to experience and knowledge, and we make 1 to 5 marks. Please give mark which is the risk of fallen for that reason. They mark that one consultant give 5, sometimes one consultant 4, according to their knowledge and experience.
Yeah,
After that, collectively we add all the things and divide it by participant and make a risk number. This is an initiative because something is there nothing. This we are initially started that, but this is not a project we stop from today. No, we are continuing. We are evaluating regularly. If any adjustment, we will change it.
Any more questions? Otherwise, we will be able to conclude this presentation.
Thank you.
Thank you very much.